صوتي مسموع سامعني؟ السلام عليكم الأول. سامعني يا أمير؟ يا رب.
يا دكتور بهاء.
الصوت مسموع كويس ولا بعيد؟
مسموع يا باشا. البي دي ايه مفتوحة يا دكتور بهاء، الحق.
كلها حاضر. تمزح يعني
حبيبي.
تمزح.
انا اللي شلامين بس.
ماشي، تقلش عليا يا أميرو.
حبيبي يا دكتور بهاء،
آه.
وحشنا.
ده أنا لسه شايلك من تحت إيد هلال يا أميرو.
حبيبي يا دكتور بهاء، ما انت اللي جايب لي الكلام اصلا.
برضه. هو
حبيبي.
التطوير في الزمان ده يقول عليه ضعيف برضه.
حبيبي يا دكتور بهاء، منورين يا شباب.
دكتور عبد الرحمن، اعمل كونكشن للسماعات للمايكس لو سامعني. آه. يا أولاد، الجيوب الأنفية ديت صعبة أوي. يقول لك الربيع عاد من تاني، عاد من تاني يا راجل، بس ماله الخريف طيب؟ أثر معاكم في إيه؟ أنا خرجت ولا إيه؟ صوتك مش واضح يا دكتور. افتح المايك كده يا دكتور عبد الرحمن بعد إذن حضرتك. كونكشن للمايك. طب سمعنا؟ يا رب.
السلام عليكم. السلام
يا أهلا.
عليكم.
أهلا وسهلا دكتور عبد الرحمن.
مساء الخير جميعا. تحياتي لكم.
تحياتنا لحضرتك. اعمل
الله
كده حضرتك
يعافيك.
سلايد شير.
شيرنج. ايوه شيرنج،
سلايد
اوكي
يكون
الان
في شير
شيرنج
كده.
ولا لا؟
ايوه. حرك كده. يا جميل. جميل تمام.
تمام.
أقدم حضرتك وتبتدي على طول. بسم الله الرحمن الرحيم.
خلاص ولا يهمك.
يا أهلا وسهلا بحضراتكم. معكم دكتور بهاء الشيخ، استشاري طب الأطفال واستشاري التغذية العلاجية ورئيس المؤسسة المصرية لأطباء أطفال مصر. نلتقي بحضراتكم في ليلة جديدة من ليالي الخبراء العرب. الليلة النهاردة هنرجع ونطير تاني للمملكة العربية السعودية، ويشرفنا ويحاضرنا الزميل العزيز المحترم دكتور عبد الرحمن الحربي، consultant neonatal intensive care and general pediatric consultant. رئيس وحدة العناية المركزة لحديثي الولادة بتجمع القصيم بالمملكة العربية السعودية. شرفت ونورت دكتور عبد الرحمن. إن شاء الله نستفيد كتير النهاردة في المحاضرة. محاضرتنا النهاردة عن البيتن دكتس ارتريوزس Diagnostics Insights and Treatment Approach. يا أهلا وسهلا دكتور عبد الرحمن.
يا أهلا وسهلا. شكرا دكتور بهاء. شكرا for this introduction. دكتور بهاء الشيخ is يعني my respected senior doctor physician. I had the chance to work with him. He's a great guy and we had the chance to work together. And really, I learned a lot with Dr. Baha. He is one of the best physicians now, especially he's very interested in the nutrition section, and which really I like, especially I'm a neonatologist. So I'm really glad to speak today about PDA with our colleagues from Egypt, our teachers, our professor. We had since long time since Saudi Arabia established. We had a lot of doctors, a lot of professors, a lot of teachers, especially from Egypt. Special thanks for them. And today, really, I'm glad to share with you my experience, my knowledge in my unit about PDA, ductus arteriosus, diagnosis, insights, and treatment approach. And I would like to share or to participate from the audience, so we make it interactive slides. So I may ask, do you have a neonatologist with us today, or mostly pediatrician?
يا أمير بعد إذنك معلش نحاول نفتح المايكس للزملاء اللي يحب يشارك يرفع إيده ويرد.
Yes.
أمير، دكتور أمير.
تمام، اللي يحب يشارك يرفع ايده بس. raise your hand. تمام دكتور محمد.
Yes. So do we have here neonatologist?
يقفلوا كلام.
خلي بالنا من المايكات يا شباب، المايكات.
Okay. So I'll start.
معاك يا دكتور عبد الرحمن. انا نيوناتولوجيست في مستشفى طبرجل العام بتجمع الجوف الصحي. الحمد لله.
اهلا وسهلا شرفنا فيك. الله يعافيك. شرفنا
أنا
فيك.
في المستشفى وحد خبرة كبيرة جدا في النيونيت، بسم الله ما شاء الله، من أعمدة عمدة طبرجل.
ما شاء الله تبارك الله. والله تشرفنا فيكم جميعا. تمام.
الله
طيب
يحفظك.
okay, we'll start our today talk. Okay, and we will discuss. We'll make it like a discussion slides. We know that we have a lot of senior doctors. I'm not here to teach anyone. We are here to share the knowledge. Okay. So as you know, usually PDA, it's a topic associated with the preterm, premature babies. When I say premature babies, that means those hospitals are level 3 hospitals who are facing a lot of premature babies, and sometimes hospital level 2, they are facing some of premature babies with PDA, but eventually they are transferred to the tertiary hospitals. So if anyone work in a tertiary hospital, definitely, or premature babies, definitely he will share a lot of experience. اوكي. ممكن بعض الشباب المايكات. الله يعافيكم.
تمام يا دكتور خلاص.
Yeah. Okay. So first thing, if we go back to embryology, okay? So embryology, all the time, the pathophysiology, the embryology take us back to how the heart actually created and how it's worked during the fetus life. And this is give us a hint to comprehensive treatment after birth and management depending on how the fetal life was. As you know, all of you, patent ductus arteriosus, it's a connection between the pulmonary or the aorta and the pulmonary artery to make a communication between two parallel systems to supply the fetus during the fetal life. So, as you know, there are a duct which is called PDA, but there are other ducts. Anyone can tell me what other ducts, or share with me the knowledge? What's the other ducts? ايش رايك يا دكتور طبرجل؟ احنا نحب طبرجل.
ductus venosus دكتور عبد الرحمن.
Yes, ductus venosus, and we have actually 3 ducts. Okay, One is
Yeah,
ductus
yeah.
arteriosus, one ductus venosus, one foramen ovale, okay? And those make a connection between the circulation, between the systemic and the pulmonary circulation. How did the arterial ducts kept open during the fetal life? What do you think, doctor? How it's kept? And just we share. I know, wallah, I know everyone knows the answer, but just to share the knowledge with us, just to remember the knowledge. Because the supply of placenta for prostaglandins, right? So prostaglandins or the placenta, it's give enough supplement of prostaglandin to the PDA to keep it open, okay? So during the fetal life, it's open. This duct is open, the fetus duct is open, the PDA duct is open, okay? And this is thanks for the effect of prostaglandin. It's make it open, okay? And what other things keep the PDA open? ايش رايكم يا دكاتره؟ What do you think about the effect of oxygen? Is it something will close the duct or open the duct?
Oxygen will close the duct. So if it's not oxygenated blood
Yes.
around it, it will keep open.
Yes, I see many answers in the chat. Sorry, I couldn't see before. Yes, you are right. Absolutely. So thanks for the low tension oxygen, which keep the duct open. We have a lot of factors like the oxygen, like the prostaglandins and the pressure itself. So it's open, the duct open. So once the mother gave the birth to the baby, and physiologically, what will happen? So we'll have a difference now in the pressure. We'll have raise of the systemic pressure due to higher oxygen level and the cut off of the placenta prostaglandin. So you have انت قطعت السورس حق البروستاجلاندين رقم 1 من البلاسنتا. رقم 2 انت عندك higher oxygen tension which will cause the duct to close, and you'll have a higher because the lung now filled with air instead of water, so you'll have higher pressure in the systemic comparatively to the pulmonary circulation. Okay. So after the birth, what will happen? So if I may ask, what is the time for physiological closure and for anatomical closure? Yani I can see the chat now. If anyone can to participate, if anyone want to participate, yes, you are right, Shayma. Yes, you're right. It's 48 to 72 hours. Those for the physiological, and the anatomical it's take maybe 3. أنا دائما أقولها 3 days, 3 weeks. 3 weeks the anatomical closure, and 3 days is the physiological closure. Okay, very nice. Excellent. Yes, 3. So I remember it like 3. Okay. Okay, next. Right. Fetal life, we discussed this is increased systemic, so in post life, what will happen? Increase systemic flow, gradual decline pulmonary pressure, increase arterial oxygen tension. This is we all talk about it. Okay. So in contrast, yes. Now we'll come to the premature babies. What is the mechanism that lead to persistent PDA? Okay. So despite the term babies, those premature, they fail this mechanism. Okay. And yes, of course, there is no prostaglandin from the mother, but anatomically, it's not mature enough, and we don't have a mature enough system. So that's why we'll have an open ductus arteriosus between the systemic and between the pulmonary. So usually, what is the normal duct? Is it right to left or left to right during the fetal life? Dr. Shaima? Yes, and then, yes, excellent. And then after birth, it is left to right, right? So what is the stealing phenomenon? So those babies who are born with prematurity and fails to close the duct, okay? And after some days, sometimes we'll find that the shunt is left to right, or sometimes just a few hours later, we'll find that the duct is normally left to right. And this is what is normal PDA, normal shunting of PDA, okay? So usually after birth, the shunt will be left to right, okay? Instead of right to left during the lung due to the change in the pressure, cut off of prostaglandin, whatever the reasons, okay? So the shunt will be left to right. But that will cause us a problem because, yes, what is the problem it will cause us? Because the pressure in the left side will go to the right side, and the blood will go from left side systemic circulation to the right side circulation, which is the lung, which will cause a stealing phenomena, what you call it, and it will cause accumulation of blood, more blood to the lung, and pulmonary edema. It will cause affected pulmonary system, accumulation of blood, pulmonary hemorrhage. All this will experience with premature baby. So have you experienced this complication with open PDA in premature baby? What is the worst for premature baby? Whether it is left to right or right to left shunt? What do you think? Or both bad? Yes, you are right. Now it's become left to right after birth, okay? Right, absolutely right. So now stealing phenomena, yes, both. Yes, yes, Dr. Ramana, you are right, both. Because if it's left to right, will cause a stealing phenomena. That means the blood in the system is stealed out أو مسروق من جهة السيستم لجهة اللنج. And that will cause, definitely, what do you think? What do you think will cause to the heart? If you have stealing phenomena, what will happen to the heart? We'll have, yes, you are absolutely right. Yes, you are absolutely right. Okay, so we'll have hypertrophy left ventricle, and that is a major problem. So we have left to right or right to left shunt. This will cause definitely symptoms to the premature baby, and that's what we call a hemodynamically significant change in the system, in the blood circulation system in the premature baby, and that will affect all the organs, unfortunately. So that's why we raise and, let's say, a scientific, since longer time, a lot of researches have been done to this topic, especially whether to close the duct or not, to keep it open or not, what to do. I have duct, I have to do something. So keeping the duct open is a problem, but also closing it, it's maybe has a lot of complication. And also premature itself, it has a lot of complication, like outcome of premature, like chronic lung disease, like neurodevelopmental outcome, like neck, like a lot of complications. So what we'll do in this hemodynamically significant, what we'll do, what is the best option to do? And that's what we'll review in our lecture. So previously I just discussed with you the most important thing, the birth physiology, especially just a shortcut for birth physiology. Now we'll go what to do for premature babies. Like I may ask anyone work in IC unit who give a care for babies who are born from 25 weeks till 30 weeks. Anyone work in such unit like this from 24 to 30? يعني premature baby, yes, 26 to 30. This is which hospital, معلش? Do you care about 24 or do you give a clinical care for babies who born 24? In Saudi Arabia, those babies who born less than 24 weeks, you consider them as abortion, especially in a MOH. But in some hospital, no. يعني في السعودية عندنا احنا في وزارة الصحة القانون أي خديج يولد قبل 24 أسبوع أو أقل من 500 جرام هذا يعتبر طفل abortion أو إجهاض. لكن yes, you see a lot of difference now. لكن في other hospitals, even in Saudi Arabia, they are mimicking some hospitals in Japan, South Korea. So they are giving care for those babies who are 22. Yes. Okay, Dr. Hussein. So some babies, some hospitals, so they are giving for babies even 22. يعني هنا we have now National Guard and العسكري ما أدري في أحد في العسكري أو National Guard. They are giving care, optimizing all the care from an ICU perspective, like caring, ventilation, admission, all these things for premature babies 22. And I saw myself one baby is 22, 3,500 gram, and he was discharged. I saw him in العسكري Riyadh, okay? So we have a lot of difference. It's depending on our unit, whether your unit want to give the care 24 and above, or 26 and above, or 22 and above. So it's depending. But if you go less with gestational age, definitely you'll have a lot of premature problems, okay? So that's why it's come the we raise the issue whether to treat the duct or not to treat it. Okay. Okay, let's go next slide. So PDA in premature neonate, it can result from pulmonary edema, reduced lung compliance, lipid exchange. This is we all discussed. And left to right shunt, this is all we discuss. Yes. And hemodynamic, what is the problem of hemodynamically significant? Most used measurement to determine PDA. Okay, so now you are working in an ICU and you have 28 weeks and you have low saturation, diastolic difference, and he is having periductal postductal change in blood saturation, and you have diastolic to systolic pressure, wide pulse pressure, and he's having tachycardia, and he has metabolic acidosis and hypoxia. So definitely it will come crossing your mind, okay, my baby might have PDA. So how you will assess that? So we have two schools now, whether to screen or not to screen. So do you screen for PDA? يعني honestly, in your center, do you screen for PDA, any baby? Will you wait for symptoms to come? Okay, nice. Okay, good. So I am sure that Dr. Rasha and Dr. Shaima, they go clinically, right? You go clinically and wait, صح? I saw many senior consultants, yes, they are saying, what is the benefit? Definitely, if I do echo, it will be open. So I'll treat conservatively and I'll wait till the clinical status improved. But the other side of the other part, they say, no, I will screen, I will do follow-up, I'll treat with PDA with ibuprofen, paracetamol, indomethacin, whatever. So some group, they say, I'll treat. Some group, other group, so no, I'll not treat, okay? So I see a lot of, less than 20, yes, you're right. So you'll do, some of the group, they'll do, yeah, of course. My experience for those 25 or 24 to 28, honestly, I do for them echo. I do, especially if I have hemodynamically significant. I will not do if they are stable, but if they are hemodynamically significant, definitely I will do for them echo because I want to see where I'm standing. Okay, because even the duct is open. Even a lot of studies, they are saying a lot of controversy of treatment PDA, whether you treat, whether not to treat, whether you give ibuprofen, whether you close it or not close it. There is no different in outcome in neck and chronic lung disease. All this, I will not ignore it. PDA, I cannot ignore it. Do you agree with me? Will you ignore PDA or no?
No,
yes,
of course.
excellent. Yes, okay, excellent. So one of the most used measurements to determine PDA is hemodynamically significant, is the ratio between the left atrium, which we call it LA, and the aortic diameter, root diameter, which we call it AO, by mode, mode echocardiography. Any result more than 1.5, more than 1.4, it's considered to be left-sided volume overload secondary to increased blood return from the lungs. Okay, so do you do echo by yourself or you call the cardiologist? Because some centers know we have an expert in neonatology, they do the echo themselves. So what is your experience in your center? Not ignore because
والله دكتور عبد الرحمن not available echo in our unit يعني.
So okay, doctor, what you'll do? What you'll do?
You know us. We are waiting for cardiologist يعني.
والله ما شاء الله عليك.
What should we
طبعا
do?
دكتور، طبعا اطباء في طب الرجال they don't have any equipment, but ما شاء الله they are running the unit with very less mortality and they are depending on the huge experience. ما شاء الله والله we are proud of you. ما شاء الله تبارك الله.
ما تنشرش غسيلك يا محمد ده كمان. ما تنشرش غسيلك يا محمد ده كمان.
ما لازم اقول الصراحه يا دكتور.
على
شهاده والله
متغطي.
نعتز بيها يا دكتور عبد الرحمن، يعني
الله
جزاك
يعافيك.
الله خير على رفع المعنويات الجميله دي.
لا بالعكس والله احنا نقول الحق والله. يعني you are running unit without equipment and you have lower mortality. يعني it's a really good achievement ما شاء الله تبارك الله. That's why يعني you are handling يعني it's not a small unit. It is 2000 or 2000 or 4,000, I think, live birth per year. It's a big unit, actually, but you are managing that, and we are proud of that, really. So, okay, so now you do echo, you will do echo. So you found the PDA open. So when you say it's significant, this is one way or one measurement when LA ratio to AO 1.4 or more. This is considered to be significant. But also, I always like to go see my baby clinically. صراحة, يعني whenever I do echo, okay, I'll see the echo. I'll see whether it's large PDA, not or small PDA, the direction. It's okay. They are giving me the measurements. The cardiology, they are very nice guys. They give me, they say your baby is duct is open and blah blah blah. But all the time I go for monitor, because monitor will give me the good reading and the excellent reading. He'll show me. Also, I'll see my baby clinically. I will not ignore blood gas, metabolic acidosis. I'll see if heart rate is high, white pulse pressure. This will tell me my baby is having significant hemodynamically PDA changes or not. So I think most of you agree with me. Since cardiologists or cardiologists are doing echo, but they are not sharing the management. You will share. You will stay with the baby. You're stuck with the baby. So that's why you see our friends in Tabarjal Hospital. They don't have nothing. They don't have echo. They don't have nothing, and they are caring premature 28 weeks, 27 weeks, and they're surviving. Why? Because they go clinically. Okay. يعني دكتور حسين دكتور بهاء he stand with the monitor and see the baby clinically, then he decide for treatment. Okay, so I think echo screening is just a fashion. A new fashion came and giving a lot of dilemma, because many babies, they are not hemodynamically significant, but you screen for PDA. Either they are small or you just want to do screening, or the unit forces you to do screening according to guideline. But then you found the PDA is open and you're stuck with the retreat. Either you give ibuprofen, then you start to give ibuprofen or paracetamol, then you have a lot of complication like neck, like a lot of things. So a lot of things we may consider why we are treating PDA. Also in our unit, there is no cardiologist. Okay, good. Excellent. Okay. So we'll go next. Okay. Okay, now we'll go for echo assessment. Anyone, do you have cardiologist here in our meeting today? Dr. Baha, في cardiologist.
لو في كارديولوجيست يرفع ايده يا شباب. مش عارف، ما اعتقدش.
ما في؟ يس، مشكلة، هذه مشكلة.
Yes.
يعني ما نقدر، يعني I cannot talk much about echo because we have someone cardiologist now. I'll show some echo picture, and please, Dr. Abir, if I say something not true, please you may correct me, okay? So I'll show you now some echo pictures. هذه نزلها تحت، okay. واضحة؟ Is it clear؟ دكتور بهاء، هو البرزنتيشن واضح ولا فيه الشات واضح ولا شيء؟ هذه واضحة؟
شغال كويس.
واضحة؟
واضح.
Okay. So what do you think this is an echo؟
اثنين كارديولوجيست. دكتور انس موجودة برضه.
اي ما شاء الله. اوكي. So دكتورة يسرى، حابة تشاركينا في هذه الصورة ولا؟ دكتورة ايناس؟
لو حابة تشاركي دكتورة ايناس ارفعي ايدك نفتح للمايك.
اي
افتح المايك. منير انت موجود؟ هم ثواني.
المايك متاح، هي كاتبة في الشات.
طيب يلا نفتح المايك. افتح
PDA
المايك.
with bidirectional front. دكتورة إيناس مجاوبة.
PDA with bidirectional.
Okay, good, excellent. So it is first we have views. Okay, when you have echo, okay, you have a views, and maybe Dr. Yusra or Inas. I think Inas and Dr. Abir.
السلام عليكم.
السلام ورحمة الله.
أنا دكتورة إيناس عبد الستار، كونسلتنت بيدي كارديولوجي في الطايف، في الماترنتي الطايف.
شرفنا فيك يا دكتورة، فرصة سعيدة نسمع صوتك.
أهلا وسهلا بك.
الله يعافيك. دكتورة, you want to, and I like my presentation to be a shared discussion between our experts who are today here in our meeting. So what do you think about this echo, Doctora? You may tell us
طبعا
about this. Yes.
طبعا we have a dilated MPA, we have bidirectional very large PDA. Could be behind it. What's behind it? We have to know. Yeah.
Yes. So all the time we'll go
large
limited.
bidirectional PDA. There should be something major behind it.
Yes. So I think this is a 2D, right? A 2D echo, right? It's not a 3D.
Yes, 2D. This is 2D.
2D, and the right side it is colored.
Yes.
Yeah. So usually we have a views. This is a parasternal short axis, and I'm sure Dr. Inas will say we have long
This is
axis.
ductal view. Yes, ductal view.
Yes. Yes. So this is the ductal view. So okay. So the direction, you can see the direction. Usually you will not see these colors. I'm right, Doctora? And if the PDA close, you'll not see the shunt.
Of course, yes.
Yeah.
I see clearly 2 branch, not 3 branches from the pulmonary. Not
yes.
3, yes, not the 3-finger sign.
Yes, yes. And this is, I think, between the short axis, usually, it's between the aortic or aortic root and pulmonary root, I think, where the...
Ductal between the aortic root? No, just distal to the subclavian originus. Juxta, yes, after the subclavian origin. The aorta after the subclavian origin.
Yes, yes,
and
excellent.
The branching of the pulmonary. Yes.
Yes. So as Dr. Inas said, we have a direction of PDA shunting bicolored and specular Doppler, left to right, right to left, bidirectional. Thanks for medicine. Show us now. We have PDA. We can read the PDA. Before, imagine like guys in Tabarja, they don't have this machine. So they don't know whether their baby is open, duct, not duct, open. Okay. So it's usually, but remember, if Dr. Inas said now, okay, I can read for you with the echo, but please give me some clinical stats about the baby. صح ولا لا دكتور ايناس؟
Some what?
Yeah.
Sorry, I didn't hear well.
Yeah, I mean, you said, okay, I can read the echo, but we have to take some clinical points about the baby.
Of course, of course.
Yes,
of course,
yes.
Of course.
So that's what we are saying. Yeah. So we have a lot of views. Okay, you can read the echo by 2-3 view. Okay, but definitely you'll go for.
We are doctors. We are dealing with a human being. We have to take him collectively. Yes, we are not taking picture or videos. Yes, of course.
Yes, yes, good. We are not a technician, as you said.
Yes.
Yeah. So okay, so we'll go for the next. So how many usually views we are using? We are using long axis, short axis, right? And substernal, I think.
Subcostal is the most important one in preterm and the neonates.
Okay, good, excellent. Subcostal. I think I have a view for subcostal. This is I don't know why the video is not working. This is apical chamber. What about the apical chamber?
Apical chamber could give me a hint about the hemodynamic effect of the PDA if I found the LA dilatation, LV
so
dilatation.
We'll see the left atrial dilatation, and we'll see the right and left ventricular dilatation. Yeah.
Yes.
So apical chamber always will give us the hemodynamics زي ما قالت الدكتورة إيناس. And also we'll have subcostal view. This will assess hemodynamic impact of PDA and moderate or large PDA, cause whole systolic flow reversal in abdominal aorta. Maybe Dr. Inas want to comment on this picture?
Yes, I have. First, I have the line, very apparent in the aorta, the central line, and we have, yes, but it is a pulsatile flow in the aorta. This is and we have a reversal, yes. So suggestive of either
holodiastolic flow reversal in abdominal. Yes, it should be not. We should not have a reversal flow.
Yes,
right?
we should have one flow. It should be all upright.
Yeah, and this is, I think, the line below the line. We should not have this. ما أدري الماوس واضح ولا لا؟ الماوس واضح؟
Yes.
Yeah, I think this is, we should not have it, right?
Yes, of course.
Yes, okay, good. So now we see some views. Usually the cardiologist will come screen for you, the PDA. Usually he'll do it in, I think, 5-10 minutes. So he'll do the screening for you and he'll tell you your opinion. But he'll leave the baby for you. He'll say, okay, you go clinically, you see your monitor, you see the color of the baby, you go clinically and you treat your baby. You want to do ligation, I do for you. You want to treat with paracetamol? Okay, up to you. You want to go do endomedicine? Okay, it's okay. You have. You want to go with ibuprofen? Is okay. So that's
So
why we
this
have a
is
lot.
the decision of the neonatologist, the paracetamol, ibuprofen, or something, or the cardiologist, because this is a debate between me and the neonatologist in our room.
Yeah.
Usually they leave it to me.
Yeah. No. It should be done by a neonatologist, actually.
Yes.
Yeah, because the neonatologist, he will review the clinical status, the dynamic. The problem of premature babies, they are very dynamic. متغيرين في اللحظة. They are not static. They are not like big babies. Static. Okay, you will see the baby static. You will the heart function is the same. No, the baby of premature babies before 10 minutes, its direction is right to left shunt. Then after 10 minutes, it's left to right. It's very normal. And below 5 minutes, it's room air. After 5 minutes, it's in high frequency. It's very normal. So they are very dynamic. So the neonatologist, he will see all the dynamic of the babies and he will follow through and he will decide the treatment of what. But definitely, we need the cardiologist opinion. Definitely, the cardiologists have a significant impact on the treatment of premature, and he'll tell you whether you are going right or not. And also, they will have a management for post prematurity life. Like suppose the baby survived and discharged in 2-3 kg, and they still have open PDA. So definitely at that time they will do the transcatheter ligation or the transcatheter closure, right? Right, Dr.
Yes.
Inas?
Yes.
Yes. So at that time, so their effect or their impact is more than when the baby inside the ICU. Okay. So okay, so we'll go to
usually the decision usually it is combined between the cardiologist and the neonatologist.
Yes, definitely. Discussion all the time give us a clear picture, a clear image.
Renal function of the baby, renal function,
of course,
everything.
Yes, of course. And also will give us like what we call it, two minds always better than one mind. A discussion between two departments. I know a lot of debates between the neonatologist, cardiologist, but a discussion all the time gives us a good clinical picture.
Usually complementary better than standing against each other. Complementary role between us is usually getting the benefit for the baby.
Yes. It's a need teamwork to decide.
Yes.
And maybe Dr. Inas, mashallah alayha, she's very keen cardiologist and she want to know about I see many cardiologists, they do the echo and they leave you alone. But she's asking about the renal function and she's asking about the clinical status. That means she's a physician. She want to know more about the baby.
Yes, I'm pediatrician. I am pediatrician in the origin.
Yes, we wish. But we wish to share this attitude with the cardiologist. And you know what I mean? A lot of cardiologists we see now, they're just doing the echo and they go. Yeah, especially in the busy center. Okay, so just you do echo and they go.
Usually we don't. I think we are the busiest center in the kingdom. We have 121 incubator.
Okay, good. So do you discuss all the cases?
Yeah, usually yes. That's a burden, yes, but usually yes.
But do the other cardiologists behave like you, or it's different between cardiologist to the cardiologist?
Actually, I was here since 8 years, and I assessed attitude between the cardiologist and neonatologist. اليانجرز اللي بيجوا بياخدوا نفس الاتيتودز الحمد لله so far.
الحمد لله. Okay, we wish to continue really because
أنا أستاذ الجامعة. I'm actually a professor in pediatrician in Cairo University. That's why teaching and trying teamwork, and it's one of our innates. That's why I'm practicing. This is my unit. Alhamdulillah ta'ala.
والله we are proud يعني دكتور بهاء ما شاء الله عليك انت ما شاء الله جايب لنا ما شاء الله the most expert يعني in the field يعني you're bringing them to the lecture ما شاء الله عليك دكتور بهاء والله I'm happy for you دكتور بهاء running such a huge summit like this daily lectures. I am really proud of you, Dr. Baha, and I really I would like to continue either as a listener or as a speaker with you, really, because we are sharing the experience between the experts, which is very nice, really. So we'll go back for the topic: medical closure or surgical closure. So we go indomethacin, ibuprofen, paracetamol, mono, combine, ibuprofen. So what you will do? I tell you, in Saudi Arabia, mostly going with ibuprofen and paracetamol, right, Dr. Inas?
Yes, but actually,
Yes.
most premature babies have contraindication for ibuprofen. Actually, when I
So mostly they go paracetamol, right?
Paracetamol, yes.
Yes, but
paracetamol is more used.
Yeah, but ibuprofen has better result, right?
We could argue with it.
Yeah, okay,
yes,
we could argue. You're right.
Better, but much more
complication. More
yes.
complication, you say. Yes, you are absolutely right. And the literature actually, a lot of literature argue with that. That's why I raised my question today. Whether you treat or not to treat. This is my question, the lecture question. You understand me, Dr. Inas and other audience?
Hemodynamically significant PDA in premature is very devastating, actually.
Yes, devastating. Yes, you are absolutely right.
Either symptomatic, either if I have lung congestion, I should restrict the fluid a bit. Maybe I could add some diuretics, and I consider.
And this is what we call it, the conservative management before the clinical management. Yes. Okay.
And combined with the medical closure trials.
Okay, excellent. So we'll go through the lecture, and we'll go through some articles I share with you, so we can, at the end, we have good discussion. Okay. So now I'll go for the my slides. So I'll go for the first lecture. في lecture كانت هنا. أيوة لا في surgical في وقتها. أيوة conservative management. Okay. So now, as Dr. Inas mentioned, okay, we have a conservative management before everything. So before you call cardiologist, you see the signs and symptoms. You go, please, for conservative management. Please, first thing you do. So what you'll do, so you have a ventilator. Your baby is intubated. So what you can do on a ventilator? Definitely, you will not give a lot of oxygen that will affect. So you lower the inspiratory time, and you'll give more beep. Okay, so this has an impact, a direct impact for the PDA closure. Okay, fluid restriction. Definitely, you will not go higher than 130. You'll go below 130 because also that has an impact, as Dr. Inas said, and also in this lecture. This is actually very good slide. This one, I take it from one professor. So he said, you do this first, then you discuss about your cardiologist, and then you accept permissive hypercapnia. Make the CO2 higher, go to up to 65, no problem. Do not go for high frequency fast, then go to back conventional, then go. So you'll play with the dynamics. Do not play with the dynamics. Go gently, slowly. You see, lower respiratory time. It's always gentle. Beep, more beep. Keep more the alveolar open. Fluid restriction, permissive hypercapnia, mentis fiber hematocrit. Also avoids the correction of certain circumstances that may lower pulmonary resistance, which are the alkalosis, excessive supplemental oxygen, nitric oxide. So all this. Some people will give nitric oxide initially. They see like difference and certain nitric oxide, and this will make the thing worse because you'll open the PDA more, and you'll give a lot of problem to the lung, leaking to the. You will enhance the stealing phenomena more. Okay, so furosemide you can use it, but it's a controversy again. Using of furosemide. Okay, so we'll go the first lecture, the first literature. It was published by Train, paracetamol for PDA in premature low birth weight. Okay, what was the result for this? Okay, so this is the result was using of paracetamol is somewhat it's the same effect of indomethacin. And this is again ibuprofen. Usually they started first the ibuprofen. They started to mention name of ibuprofen, then they started mentioning of paracetamol, because back in time they use only indomethacin, which has a significant and back complication. So now they raised the issue of using ibuprofen or paracetamol, which was discovered accidentally. And now the trend now going with paracetamol or ibuprofen with lower side effect. Okay, try to treat with the lower side effect. If not, please keep the duct open. Just play conservative, and that's it. Okay. So this is our center. I just shared the picture. Okay. So we have a big center in Al Qasim. We are dealing with a lot of cases like congenital heart disease. We have Transcath, we have LabCat. We are doing a lot of things. I think more than 4,000, 5,000 cases per year. They're treating adult and in ICU. So luckily in my center, I have this center, Prince Sultan Cardiac Center in Qasim. Okay, and this is a picture from it. Okay. So surgical closure, unfortunately, surgical ligation has a frequent been linked to increased comorbidity, including BPD and ROB long term. So زي ما قلنا احنا, we have a complication. We want to avoid complication. Okay, you take your baby for surgery, and you, mashallah, successfully close the BDA. But at the end, you'll have a lot of comorbidities like bronchial dysplasia or chronic disease like ROB long term. So what is the benefit of closure? Nothing. Okay. So trial of endomyositis prophylaxis in premature baby also inpatient endometrial ligation had more. So those baby who go for surgery, even they have more complication than endomyositis. So most of the literature review the comorbidities associated with your treatment, whether it's surgical, paracetamol, endomyositis, ibuprofen. So they want to, okay, go close your BDA, please. When you go to close your BDA, please look out for the complication associated. Okay. And the problem with surgery that what we call it a termed post-ligation syndrome. Have you ever heard about it? Post-ligation syndrome. أحد سمع عنه يا شباب؟ هو a sudden increase in afterload and decrease left ventricle LV and occur following the ligation, putting the neonate in higher risk for decreased cardiac output, cardiac deterioration, termed post-ligation syndrome. And this is really, I don't like about ligation, and really I keep it the last option to do is the surgical ligation. Okay, I don't know, I think Dr. Inas maybe agree with me. The last thing I can do is the surgical ligation. I have a lot of things to play before.
Our
Right.
guideline, if the baby have hemodynamically significant PDA beyond 28 weeks, still in need for mechanical ventilation high settings, this is the one indicated for surgical ligation.
So you mean it is the last? It is the last.
Yes, it is the last. Maybe through these 8 years, maybe I have only transferred 3 patients for surgical ligation of PDA.
Yes, you see. So surgical ligation is trending down. It's not a good option. So that's why we are going with more with conservative or medical treatment. Okay. So transcatheter closure. This is actually for those. This is actually it's very good. It's a very good thing to do, but it is weight dependent, and it is hemodynamically significant dependent also. So we have a study. It's called transcatheter BDA. Large meta-analysis done, assist the infant undergo percutaneous closure, BDA published by Bix 2017. صلحوا closure ل 635 within the 38 studies, 92 were successful closure rate. Adverse was noted in 23 and only 10% being clinically significant. So, but this is done, I think, after 3 kg, 4 kg. صح, Dr. Inas?
Yes, not less than that. Usually,
Yeah.
because you affect the vessels with
Yes.
a complication of limbing or something like that.
Yes. So you'll see it later on, not in the beginning. And this is also again, it's not helpful for me inside the ICU, but maybe helpful when I discharge the baby outside the ICU. Okay.
Yes.
Okay, we'll go. طيب. To treat or not to treat, we have also another study, conservative management for BDA, systemic review, analysis, assessing the difference between outcome measure between randomized. I make summary for it. So this is a study to evaluate outcome after conservative management versus no management. يعني so compare whether you give only conservative زي ما قلنا اللي هي mechanical ventilation, low setting, restrictive fluid, and with medical. So what they found, 72 out of 72 patients in the RCT revealed that no significant difference between the outcome between the conservative management and active management. Okay, but this is a lot of let's say different compounding factor, what you call it. So some of those babies who are extremely premature, hemodynamically significant, some of them So a lot of variant. But at least they found the end result, there is no difficulty, there is no significant. That's what is again the question. Shall I give ibuprofen? Okay, I know paracetamol has a lower side effect, but even shall I give paracetamol? Still, it's still a debatable question. So the big question: shall I treat or not treat? This big study, see this one? Yeah, this big study, and it's showing me 72 patients of RCT enrolled, and there is no difference in outcome between conservative management and active treatment. So this is, they call it conservative management and active treatment. And that's why I raise a question again: shall I treat or not treat? Okay, this is again another question: early treatment versus expectant management in hemodynamic significant. So this is another study done also in Cochrane. So they found the data whether you treat those hemodynamically significant or not. So this is study RCT, which early pharmacological treatment defined a treatment initiated within first 7 days. Okay, they compare with no intervention or placebo. Okay, يعني هم جابوا 910 infant. Some of them they receive pharmacological treatment مثل الباراستامول, الإندوبيتريسين, ibuprofen, okay, and they compare it with those who said no, I would go for conservative treatment. So what they found early treatment defined. The result is they found no difference was demonstrated between early treatment versus expectant management regarding of mortality and chronic lung disease and severe IPH and neck. So can you imagine, for those people who receive medication and those people who conserve management, there is no difference. Because at the end of the day, okay, maybe like the Inas or cardiologists, they just look for PDA, whether it's closable or not, because this is the hemodynamically picture that they are looking for, because they're talking about cardiology side, but we are talking about a lot of comorbidities later on for premature baby, which are chronic lung disease, mortality, IPH, neck. So if there is no difference in because the premature, it's themselves they have problems, right? So that's why. Yeah. So no difference demonstrated between very early treatment and versus expected management in all these measures. Okay. Early or very early pharmacological treatment probably does not reduce the mortality. We have also an indicator for every ICU in Saudi Arabia, also in Egypt, everywhere we have to look for a mortality rate. By the way, what is the mortality rate in an ICU in Egypt? Anyone has this information? It's
depend on the
usually
center. Depend on the center.
هو usually published by WHO a number for all the whole country because Ministry of Health of Egypt has to deliver this information to WHO. Anyway, Saudi Arabia has come within the good range, alhamdulillah, 3.5 to 4, which is almost similar to Canada, to USA. This is regarding Saudi Arabia, but not like Japan, not like South Korea. They have the lowest mortality rate ever in an ICU. They just have 0.8 per 1,000 life birth, which is really significantly very, very low. What do you think the reason for that? And I like to hear from the audience. Why the Japan and South Korea, they have the lowest mortality rate? 18, yeah, it's quite high number, Dr. Hiba. Very high, 18, very high. In Saudi Arabia, it's 3.4 to 3.4, or 3.5 to 3 to 4, okay? So in Japan, it's 0.8. In South Korea, it's 0.8. Good antenatal care, excellent. Good antenatal care is one fact. Yes, but in Canada, do you think they don't have antenatal care? Good. Yes, they have good antenatal care, but still they have higher number like Saudi Arabia. Saudi Arabia is coming in the middle group, not in the lowest group. Infection, yes, you are right. Infection, yes. Dealing with money, yes, you are right. But maybe I wonder that also I review many studies. The genetic and environmental factors are affecting too much. For those Japanese and Korean babies, they have a strong genetic behind them. They born, yes, 26 weeker, but they're very strong babies because even, yes, survivors. Yes, you are right. So تعرفون القط اللي بسبع أرواح سبحان الله. Those share a very strong genetic, and that's why also they have a very good lifespan for elderly, right? تشوفون اليابانيين الكوريين دائما نحاف، قصار القامة، طويلين الأعمار. This is all genetic factors. It's affect. But the other things, very important factors like infection, like antenatal care, like survival. Like suppose in Egypt, in Saudi Arabia, maybe دكتورة, let's say infection Mona or Dr. Mirbet, you have a baby 26 weeks and diagnosed antenatally Down syndrome. What will you do? What do you think? What will you do? You will abort the baby? تقولين للأم والله abortion خلاص ولا نخليها تولد؟ داون سندروم هو يعني ممكن حد يشاركنا؟ Yeah, my question is, you have a baby who is 26 weeks, diagnosed antenatally, now still not birth, still is mother is pregnant at 26 weeks, diagnosed, let's say a fetus, diagnosed with Down syndrome antenatally. Now you know all the features, and you did NIPT and IBT test, and you did amniocentesis, you did karyotyping, and you found it is Down syndrome, clear, 100%. So how you deal with the mother? Oh, just general question, whether you go for abortion, past 19 weeks, yes. Better to give her choice. Yeah, طيب Dr. Hussein, you are giving her choice, but what about ethical and religious aspect? Our religion, our ethical, do you think they accept the choice? No abortion, yes, no abortion. I agree with you. طيب, in Japan, in South Korea, in USA, they don't do abortion. Sorry, they do abortion. They do abortion for Down syndrome. And that's why all the Down syndrome, all the trisomies 18 and 13, this is according doctor name. Yeah, but it's still fetal, we don't know. Chance of delivery. Yes, you're right. So the question, or the main answer we get, that those countries who have lower mortality rate, actually they abort all the babies with multiple congenital anomalies, whether Edward, Down, Fetal, or what you call it, this one with the severe oligohydramnions. I forget the name. With almost no butter, yes, butter syndrome, yes, very raw butter. So all these they aborted, and those babies. So those babies, so it will not be counted in the mortality. You see the trick? So in Saudi Arabia and Egypt, unfortunately, we wait, we go for tertiary center, and the Edward delivered, and after 2 months died, and it is counted in mortality. So what is the benefit? You got my point. So in Saudi Arabia, the rule now, unfortunately, we don't have fetal maternal, but the rule now for Edward and Fetal, because they're not compatible with life, you can abort them even 37 weeks or 33 weeks, but in a specialized center. But only these anomalies, Edward and Fetal, only. The other Down, no discussion about it. It should be delivered even if it's covered earlier. Again, it will raise a lot of ethical and religious consideration. I don't know, maybe it's need another lecture. Maybe Dr. Bahai, he will arrange for us a lecture like this. So what to do with antenatal management, diagnose already congenital anomalies, whether to deliver or not deliver, and what is the input of fetal maternal medicine for that, because this is eventually will decrease our mortality rate and will improve the health outcome overall. What about parent decision? Yes, you are right. Yeah, Dr. Hiba, you are right about parent decision. But again, يعني معلش هو after 4 months نفخ الروح، في نفخ الروح، فهو life there. يعني في life. Yes, sure, ethical register. Yes, that's why we have to look for it. يعني to discuss it more and more. It's need actually a separate lecture. Anyway, I'll go back for sorry for diversion, but I'll go back for the lecture. So we'll have also another study about treatment of PDA at 1 year or 1 year, sorry, 1 week. This is published in JAMA. PDA closure at 1 week after randomization was significantly higher with ibuprofen. يعني they're saying ibuprofen was better than other, and the non-intervention 7.7% only. So there is increased good number صراحة. The non-intervention approach were no ibuprofen treatment in term of PPD incidence or death. The ductal closure rate before the hospital discharge was ibuprofen 62 and non-intervention 59. And there are changes in numbers, but again, the complications are the same. So again, the question, why I treat it, since we have the same question. Right, okay, early routine did not reduce the ligation. This is we discussed. This is another trial studies the effect of non-intervention of oral morphine in circulation in premature babies. The results show معلش. Now we'll go back, please. Yes. So again, to receive either oral morphine, this is actually done, randomized by placebo-controlled trial of early treatment of pediatric cells. And this randomized was enrolled about gestation 30 to 32 weeks, diagnosed between postnatal 6 days and 14 days. 146 were randomly assigned, and 72 assigned in non-intervention, and 70 with ibuprofen treatment. So what was the result? The result was, I think I did not write the result here. Randomized placebo. Effect of non-intervention for all morphine. Okay, but there was some significant, I remember this, there was some significant increase in number of closure, but again, the same comorbidities. Also, this is another trial, randomized placebo-controlled trial for early treatment of PDA. It's done in multi-center. This is a big trial, 92 infant with large PDA. What was the result? The death, the infant received early endomycin has significantly less early pulmonary hemorrhage. Okay, this is one factor. But again, endomycin has effect in renal and other organs. Also here, prophylactic intervention and preventing mortality. This is anyone experience this? This is هذه في الجامعة يعطونا اللي هو they're giving prophylaxis endomycin. I don't know anyone his center practice this one, giving endomycin for all premature babies as prophylaxis. احنا عندنا في السعودية مدينة الملك خالد الجامعية, any premature baby they give him endomycin as a prophylactic. Anyone experience this? No. Okay, good. So this is one thing they say, it decreases IBH, less chance of complication of BDA. So some centers they are doing that. Okay. طيب. So this is we discuss. Okay, single dose prophylactic again. Also some centers or some study they show another study. It's a single dose prophylactic ibuprofen therapy for pediatric circulation premature baby. So what was the result for that? It was the result. Early PDA closure was more effective with those patients who have prophylactic, but again, no difference in PDA ligation. BBDC, we review more than 6 studies. Yes, some of studies like ibuprofen and yes, it's closing the PDA, but there is no difference in comorbidity because a lot of collaborated for those people in chronic lung disease, in NIC and mortality. But again, I think a lot of genetic variation between the population in Saudi Arabia, Egypt, and Canada, USA. Canada, they have a lot of factors inducing chronic lung disease. They have even sudden infant death syndrome, chronic lung disease. In Saudi Arabia, alhamdulillah, we don't have this much chronic lung disease. I don't know about experience of Egypt. Do you have a lot of babies with chronic lung disease? For Saudi Arabia, no, alhamdulillah, we don't have a lot. So anyone can share us. What do you mean by? Yeah, this is a study. Yeah, sure. I'll show it for you. Where is it? Yeah. So this is a study, they did it, single dose prophylactic ibuprofen therapy for PDA in premature baby. It is a study. They did it. Just, yeah, they are giving just one dose. Yeah, this is the dose. Only, this is the dose they are giving 10 milligram per kg within 6 hours of life after birth. واضح دكتورة منى? Okay, and this is the result. No difference in PDA ligation. Yes. Yes, this is the result. Okay, we'll go again for another study which is done in March in JAMA, associated placebo endomycin and with hemodynamic significant PDA. هذا اللي احنا نتكلم عنه. يعني again let's see this study whether found they have any so they have primary outcome, secondary outcome. Anyway, higher dose of ibuprofen was associated with significantly higher odds of PDA closure than standard dose. So they found that higher dose of ibuprofen, it will close PDA, but again there was no significant difference in odds, mortality, NIC, IBH, all these things. There is no significance. So I reviewed you more than 10. This is maybe the 11th. Also, this is a study, early treatment versus expectant management. This is Benedict trial. This is the latest one. And the result of these findings suggested that routine early pharmacological closure PDA may be not necessary in extreme preterm. Supporting more conservative approach is better than medical management or even surgical management. One of the largest trials compare. Actually, this study published 2023. So this is the latest one. I think there is only short-term benefits for yes, Dr. Heba. Excellent. This is the summary of my lecture. There is a short-term benefits, but not long-term benefits for closing PDA. Excellent, Dr. Heba. So, conclusion: growing awareness that aggressive intervention to achieve a ductal closure زي ما يحبون جماعة الكارديولوجي دكتور ايناس تحب تقفل البي دي اي بس maybe not beneficial and should not lead to an assumption that persistently PDA can simply be ignored. يعني okay ما في effect في الاوتكم في الكومبليكيشن but do not just ignore it because it's open. Okay, go with conservative management. Okay, factors that may be delayed ductal closure such as late onset bacterial infection, you should avoid it, and excessive fluid administration more than 140, you should avoid it. Okay, and most have been presented show no difference between the treating PDA or conservative management or regarding the mortality and chronic lung disease and NIC and IBH. And PDA discharge, shall we consider treating PDA to prevent pulmonary hemorrhage even though it did not affect the mortality of PDA? يعني في ناس قالوا احنا بنعالج عشان pulmonary hemorrhage, but again comorbidity is the same. And this is my lecture. I try to share a lot of study with you, more than 11 studies. It almost show no difference between impact of clinical management or surgical management, whether comparatively to conservative management. This is raised the question again. يعني shall we treat or not to treat? This is my lecture. Any question? العفو دكتور هيبة، العفو دكتور ايناس.
ثانك يو دكتور عبد الرحمن، جزاك الله خير والله.
الله يعافيك، تسلم حبيبي.
أي سؤال لو حد حابب يسأل نفتح له المايك.
الدكتورة
في
ميرفت
سؤال
تسأل لازكس. الدكتورة ميرفت تسأل عن لازكس. اللازكس هو again controversy. You can use it according to the clinical status of the baby, your baby, but it has no significant impact on the PDA. Okay, it will drain your lung, it will drain the body, it will decrease the load on heart, but again, no difference in comorbidity, and I mentioned that in the slides. شكرا دكتور أمل، شكرا.
أي أسئلة يا شباب؟
انا عندي بس سؤال اخير يا دكتور عبد الرحمن. كنت حضرتك في المحاضره بتتكلم على الايرلي تريتمنت اور نوت تريتمنت. طب لو احنا عندنا بيبي وصلنا بيه عمره دلوقتي 28 يوم وديشارجد وري ادميتد تاني، وبعد ما عشان شيست بروبلم يعني او ميتابوليك بروبلم، بس لاحظنا ان في فريكوينت دي ساتوريشن كده، والبي دي اي هي بتبتدي كلوزنج كانت 4 ووصلت 2 دلوقتي، والكارديولوجيست اللي عمل لنا الايكو قال ان هي بيتر تو ستارت باراسيتامول. هل يا ترى الباراسيتامول في العمر الكبير ده اللي هو 28 يوم دلوقتي ليه رول في الكلوزنج، او هو ده سبب البي دي اي ليفت تو رايت شانت اللي عملت الفريكوينت دي ساتوريشن؟ وهل يا ترى الباراسيتامول في الحاله دي ليها رول في الحاله بتاعتنا ولا لا؟
Very good question. Honestly, during my review, I don't think so. After 1 month, 3 weeks, it has affect the medical management and even the conduct management. It's very difficult every day to close it after this age. So the best way, but we have to close at this age. For my center, we are closing these cases, but we are waiting till 3-4 kg. I don't think so, the rule. Maybe Dr. Inas, she shared something, I don't know. But for my review, my own experience, I don't think there is effect after 1 month. But for those people, they are best candidate for transcatheter closure. I don't know, you do it in your center or not? يعني
Could you just give me the mic, please?
Yeah, sure.
It depends on the gestational age. If the baby total gestational age below 34 weeks, we could use it. After 34 weeks, maybe for the benefit of doubt only, the use will be the benefit of doubt. But if the baby is originally 26, 27 weeks, and now he is 28 days, so plus, so he's now 31, 32. He could benefit from the paracetamol. Actually,
yes, but again, it is benefit of doubt, Doctora, because a lot of physiological changes after birth. Usually, we are dependent on the actual age, not the corrected age. But some, yes, you're right, Doctora. Some studies mention that you can use the chronological age to assess your patient to treat. But for my experience, actually, and my cardiac center experience, maybe Doctora Inas, she has another experience. I don't know. Do you use it before or not?
I use it usually يعني usually the paracetamol. I don't know, my observation is right or not. It needs to be studied and researched well. Yes. The use of paracetamol beyond the 3rd week, beyond 20 weeks or beyond 14 weeks is giving better closure effect than using it very early. Paracetamol used later is better. يعني,
I think you should study
this is observation. Yes, I should make a research about this. Yes.
Yeah, you should do observational study. Very nice. Yeah, it's a topic for a question, Doctor.
Yes.
Very nice to raise the question. Yeah. شكرا
طيب
لكم
طبعا كان
جميعا.
عندي سؤال.
But actually, I don't think the the one of the questions, the 2 millimeter PDA, it could cause such desaturation for the baby. The chest infection is the main cause, not the PDA is the cause of the desaturation for the baby. PDA 2 millimeter, 28 weeks, 28 days old baby, it's not a cause of desaturation at all, most of the time. The chest infection, yes, but the PDA itself,
yes.
no.
Yes, very nice. Yes, what's your question?
بخصوص الاستاد اللي هي عن السنجل دوز بروفين، هل احنا ممكن نستخدمه امبيريكال كده للبريترم نيبورن يعني على جالنا عشان نقلل البلمونري هيموريج، لان احنا عانينا فتره من موضوع البلمونري هيموريج ده البريترمز عندنا في اليونت يعني.
Yes, you're right. يعني pulmonary hemorrhage is a big headache for us, all of us, unfortunately, and it's related to prematurity and multifactorials actually. Single dose of ibuprofen, it was tried, like 1 dose of 10 milligram after 6 hours of life, and it shows significant, let's say, early closure of PDA, other than just leaving the baby and conservative management. But at the end of the day, even you prevent pulmonary hemorrhage, later on the comorbidities is the same. If you apply all the measures to prevent pulmonary hemorrhage itself, even with the presence of PDA, like I tell you my experience, minimal handling and suction inside ETT, it was significant impact for decreasing hemorrhage. Like we noted that most of pulmonary hemorrhage is happened due to nursing care, because they do deep suction and they manipulate too much. Also there is no gentle ventilation. يعني beep 16, then you increase to BIB increase 16, then increase to 20 because just you want to seek for more oxygenation and decreasing VR, and you know this non-gentle management. So this is all a factors. So if you decrease, if you do all the gentle management, if you do all the minimal handling, if you teach your nurses, you say, okay, we'll take more care about the babies, we'll not do suction unless it's indicated, or stop suction at all, because suction
superficial suction يعني at least.
Yeah, it's superficial. Even but some of nurses, they have the habit to go deep, okay, and gentle ventilation and minimal handling, less procedure, believe me, it will all improve. And this is my experience, my own experience. When I come here, we had a meeting with the consultant here, our unit, and we decided to apply some measures, and believe me, it has a good impact. And even I have my professor, you may contact him also after lecture. You can take my number from Dr. Baha. We'll tell you how we decrease the pulmonary hemorrhage, even with the presence of PDA or pulmonary hemorrhage or whatever. It is decreased by the conservative management. Again, you can go through this study. It's published by JAMA. It's a very good study. They found significant closure, but the outcome, the outcome mean, later on, the comorbidity, chronic lung disease, neck, there was no difference. That's why they say, okay, you can give it, but again, you have to be careful from the kidney, you have to be careful from the neck, because, you know, there is a strong link between neck and kidney problems, AKI with ibuprofen, you know that, right? Although one dose is not that much, but still, again, you have a lot of, maybe you'll have complication, and maybe if any complication happens to the baby, they will question you why you give this, and still trial and still. But again, the NICU section is 20% FDA approved. The other is all controversy. Depending on your experience and your trust in yourself, you can use some trials, but should be documented and studied well, and see the effect, whether affecting your unit or not. يعني انا اتمنى انه كانت اجابتي واضحه دكتور.
سؤال من دكتور اسلام. Do you recommend 3 days course of paracetamol versus 5 or 7 days?
Okay, very good question, Dr. Islam. For my center, we are doing for 3 days paracetamol, and then we reassess. نكلم الكارديولوجي نتابع معانا، تعال شوف البيشنت. Do you think we should extend the paracetamol or not? So we'll assess after 3 days. First we do the conservative management, then we start the paracetamol if it's clinically indicated or significantly indicated. After 3 days, we'll do assessment for the PDA. Still the same size, you can go for another course, or you can extend for 2 days. If closed, then good and go.
طيب سؤال تاني. diameter of PDA significant diameter of PDA.
والله يعني this depend. يعني ممكن دكتورة إيناس تجاوب عليه، لكن هو depend on the clinical status of the baby itself. دكتورة إيناس معنا لسه ولا؟
دكتورة إيناس؟
Hello.
Significant PDA diameter.
Diameter is not the issue at all. Yani, yes, it give you a hint, but the hemodynamic effect is the most important. If you have left atrial dilatation, LA to aorta to LA, left ventricular dilatation, lung vascularity is high. Clinically, the baby starting to have some clinical effect of the PDA, any complication. This is the most important issue, not the genuine diameter of the PDA in that age. The diameter is not.
سؤال لحضرتك برضو كالكارديولوجيست المساعد اللي بيدينا نروح فين ونيجي منين. طيب السؤال shape of PDA, does it change our judgment on it, as we many cases with cone-shaped PDA?
Cone-shaped PDA is a closing PDA. The shape, it doesn't matter. The importance of the shape for the interventionist who is doing a cast to close the PDA. But shape in the premature, it's very dynamic. The shape is changing unless it is very vertical, very tortuous. Its shape is apparently abnormal. But the shape, it doesn't affect the
the dynamicity of the premature baby. Very important. Yes. That's what I said. Yeah, that's what I said. And also, Dr. Inas confirmed this. The problem with premature babies, they're very dynamic. Very dynamic. So you have to stand close with your baby. Read the monitor. Read him clinically.
شوية اوفر فوليوم فلويد زيادة الممرضة مثلا زودتهم will change the dynamic of the PDA. هلاقيها تاني يوم ضعف. يعني it happened so. yes, it is changeable. مش الشيب خالص. It's the hemodynamic effect that apparent on the baby, whether by echo parameter or clinical parameter.
It's issue of effect of the victim size, not on the size.
Size, yes, give me a hint, but it's not the only issue.
Okay.
يعني diameter of the baby is not the only, the diameter of the PDA is not the only issue at all. يعني.
اوكي تمام. كده غطينا كل الأسئلة. في حد عنده سؤال تاني قبل ما نقفل الجلسة؟
ما فيش أي سيامية يا دكتور بهاء، عايزين سيامية.
ليه؟ عينينا كله موجود.
تسلم.
هقابله كل
هو هذا السؤال اللي في الأسئلة.
ماشي يا دكتور حسين، نديله كل حاجة بكرة الصبح إن شاء الله. What is the treatment of post PDA ligation syndrome? Should I start melurine? What is the treatment of post PDA ligation syndromes and should I start melurine for all patients?
Well, this is again a pure cardiologist question, but for me, I will decrease the load on heart. Yes, melurine is a good option. I don't know what Dr.
Yes, actually, I didn't encounter the post-operative units encounter this problem, but most of the time the baby heart is very have a good reserve. But if it happened, it would be for a short time, not a very long time, actually, because it could accommodate. If you bridge the baby that critical period, he will cope well with the post ligation syndrome.
Yeah, in the perspective of ICU, for my experiences, melurine is one of the best to encounter the cardiac output to improve it without affecting the other system, and one of the best options, especially in the neonates. So you can use it according to your clinical judgment as ICU based. Okay, but if there is suggestion from cardiology, I think it's a pure cardiac issue. If there is suggestion, you can go it, but clinically you can go, and we have seen a lot of experience with melurine. Melurine is a good medication, and it has unless the complication of it, you can use it.
جزاكم الله كل خير، والمحاضرة كانت informative interactive جميلة جدا، الناس استمتعت بيها والزملاء كلهم استمتعوا بيهم. شكرا دكتورة إيناس، شكرا دكتور عبد الرحمن على وجودكم وعلى تشريفكم لينا.
شكرا دكتور بهاء. شكرا دكتور بهاء. اعتقد ان احنا التقينا قبل كده في احد المؤتمرات يا دكتور بهاء.
لي الشرف طبعا.
تذكرني. اوكي،
ان شاء الله نتواصل مع حضرتك بعد المحاضرة ان شاء الله.
ان شاء الله. شكرا
الله، شكرا جزيلا. شكرا جزيلا.
شكرا. زملاء الاعزاء، شكرا لكم كنتم موجودين معنا النهارده. ان شاء الله بكره نبحر بكم جنوبا السودان، ان شاء الله من السودان بروفيسور مأمون العوض. هنتكلم على مونوجينيك فيسس بولوجينيك انفلاماتوري باول ديزيز، محاضره GIT ان شاء الله تكون قيمه. نلتقي بكم على خير ان شاء الله. شكرا لحضراتكم.
شكرا جزيلا. الله،
شكرا. السلام عليكم ورحمه الله وبركاته.
شكرا دكتور عبد الرحمن.
شكرا جزيلا.
مع السلامة.